So welcome everybody to our third session on COVID-19 clinical case discussion series. I know everybody is working extremely hard during this pandemic, and what has been plagued with this pandemic is misinformation or sometimes not an understanding of the latest evidence when it comes to the management of patients with COVID-19. That being said, Johns Hopkins University and JPIGO have partnered to bring to you this interactive case discussion series featuring experts from Johns Hopkins University and India. And today we're going to be featuring PG Aimer and Dr. Arun Bansal, Karthi Nalsami, and Abhijit Chaudhary from AIMS Nagpur as our Indian colleagues, and then from the United States, Nicole Shaklowski and Dr. Amina Hussain. So the purpose of these case series is not to be a comprehensive, all-inclusive session, but to really introduce a topic, review the latest evidence in the clinical diagnosis and management of these patients. And then followed by this session, what every registrant will receive is a comprehensive resource tool that will include a synthesis of the evidence in depth that was reviewed today during the session, additional courses or workshops or guidelines that you can access from home, and then some interactive cases that you can do to try out your knowledge. Please take a moment to do the pre-test. And we plan to end these sessions bang on 1 hour. But if you want to stay back and ask a couple of extra questions, you'll be more than welcome. So this is a truly, this is a truly collaborative effort. I'm going to take 1 more minute to introduce the individuals that brought this effort together. We're going to have a keynote address from our hosts today. There'll be a case presentation to really understand the thinking behind how we manage these patients in an expert center for excellence facility. We'll have a couple of questions. So during the question time, please in the chat, write out any questions that you may have. All of our experts today will be engaging with the chat, and then we'll summarize with a review of the latest evidence. Your facilitator will be my colleague today, Dr. Souvik Chatterjee, who is a medical education expert here at Johns Hopkins University and an associate professor in pulmonary critical care medicine. So I'm going to start off by inviting our hosts from PG Aimer to give us an inaugural address.
Hey, hi. Thank you so much, Bhakti. I'm sorry that our director sir was quite busy, so he couldn't make it. He was busy in the other engagement. So I'll do that honors. So it's really a pleasure that Johns Hopkins, the USAIDs, and the RISE have come together to collaborate with institutes like PGI and AIMS and other institutes in India to spread the knowledge. So this MISC is a very important topic. We all know that it's one of the significant complication of COVID, and cases we have seen first and second wave, we almost have gone through and seen one or few more of those cases and we anticipate that this will, if the third waves come, we'll see more of these cases. So to carry this forward, our team has prepared a case presentation, which Dr. Karthi, I'll introduce him. He is the associate professor at a pediatric critical care unit at PGI Chandigarh, and Abhijit Chaudhary, who is the assistant professor at All India Institute AIMS Nagpur. So they will be helping in that in the panel discussion from the Indian side. So back to you, Bhakti. Thank you so much.
Thank you. Thank you so much. And every single series will be featuring a new facility that is a center of excellence in India. So if any of you are interested in being hosts, please let our colleagues know. So this is our team. The RISE India project is led by our senior strategic advisor, Dr. Bulbul Sood, Dr. Sumesh Kumar, who is the country director for JPIGO India, and Dr. Vineet Srivastava, who is the chief of party for the RISE project. RISE has been working in India for over 10 years. And more recently, we have been focusing on COVID-19 emergency and critical care capacity, which is the genesis of this project. All of our work would not be possible without our donors, the United States Agency for International Development. USAID has been truly dynamic in how they have supported countries such as India in their COVID response. Beyond just clinical case management training, due to their championship, we are supporting laboratory capacity, network analysis, hub and spokes models, oxygen ecosystem strengthening, and many more activities. And we just really want to take a moment to acknowledge and appreciate the partnerships and support we've received from USAID. And from Johns Hopkins University, there is a small but mighty team that has been supporting this in their background. And I want to take a moment to thank Dr. Valerie Asula and Dr. Pavna Seth, who will be participating in this call and answering questions in real time, but will also be putting together the comprehensive resource document that you will receive after the session. So with further ado, I'm going to hand over to my, I'm going to quickly actually review the learning objectives. I'm going to hand over to my colleague, Dr. Souvik Chatterjee. As I mentioned, he's a medical education expert and an associate professor in pulmonary critical care medicine. He will be facilitating and will be your champion throughout the next 45 to 50 minutes. Souvik, I'll hand over to you.
Thanks so much, Bhakti, and thank you everybody for joining. This is a very exciting topic and case, and of course, we all have so much to learn. I don't want to spend too much time taking away from the great content that we're about to see. I will again encourage you to post questions in the chat. We'll have a couple of opportunities for some Zoom questions, and then we will have an opportunity to ask questions to our panel of experts. So, Dr. Bansal, I'll turn it over to you to begin the case presentation.
Thank you, Souvik. We'll start the case. Kalti will be presenting the case, and then I'll take it forward after that. So, Kalti, please.
Thank you, Dr. Souvik, and thank you, Dr. Bansal. I hope the slides are visible and you're able to hear me.
Yes.
Yep.
Yeah. So let's start. Good evening, everyone, and let's start the discussion with a clinical case which we have seen recently in our unit. So, yeah. So this is a Master S, who's a 10-year-old boy who presented to us in the mid-June, 18th of June, in the morning hours to our emergency from Yamunanagar, which is a northern district of Haryana. For those of you who doesn't know where Chandigarh and Haryana is, it's north of Delhi at the foothills of Himalayas. And this kid traveled around 110 kilometers, about 2.5 hours to reach PGI emergency room. And if you see the timeline of his presentation, it is just after the second large wave or the third wave in Haryana, which you have seen, and rightly and exactly after a month after the peak cases of COVID happened. So at the time of presentation, he had fever, which was there for 4 days duration, which is high grade, fairly about 103 Fahrenheit documented. Along with that, from day 2 of fever, he developed pain abdomen, which was dull aching, non-vocalizing, and some of other abdominal symptoms, GI symptoms, including vomiting and episodes of loose stools. On the day of presentation, he had fast breathing and worsening in respiratory status. That's the reason he was referred from the referring institution to a hospital. He did have a history of reduced oral intake and reduced activity for 2 days, but there was no history of any respiratory symptoms or upper respiratory prodrome, no history of rash, and no past history of COVID in him or any other family members, or no contact with a confirmed case. He was a healthy child, no previous comorbidities, and he was developmentally normal. So with this history, he was admitted at the district hospital in Yamunanagar for a day and managed as severe sepsis without focus. He received injections of ceftriaxone and intravenous fluids. His initial laboratory parameters showed a neutrophilic predominance in the leukocyte count and a platelet which is borderline low and a very high CRP. But once he developed respiratory distress, he was referred to our institute. At the time of presentation to emergency, there was no concern with his airway. He was tachypnic with increased respiratory efforts, and he was hypoxic on room air, which improved with supplemental oxygen to 97%. He was presented in circulatory shock with tachycardia and hypotension, although peripheral perfusion was fairly maintained. He had a normal Glasgow Coma scale and normal symmetrical motor activity without any focal deficits. Blood glucose was normal. On exposure, he did not have any rash, but we found conjunctival injection, which will be seen in the next photograph. So he was categorized as respiratory failure and hypotensive shock and triaged as level 1, which is resuscitation. So this was the picture showing his conjunctival injection, which was non-purulent and little hemorrhagic. And his systemic examination revealed no remarkable findings. His abdomen was soft, no organomegaly, and normal heart sounds without any gallop. So with this background, we kept differentials of acute infection, which we commonly see in this season, like scrub typhus or enteric fever, which is systemic infection presenting with organ failure. And toxic shock syndrome was also considered, although there was no focus of staphylococcal or streptococcal infection on examination. And MISC was one of the strong possibility in him because of the timeline of presentation and the consideration of mucocutaneous signs and presentation with hypotensive shock, although the treating team wanted to rule out other infections as well at presentation. So he was managed in the first hour with nasal oxygen and a 10 ml per kg of normal saline fluid bolus over 30 minutes, and adrenaline infusion was started at 0.1 mics per kg per minute to counter his hypotensive shock. He was given ceftriaxone and doxycycline first dose, and as MISC was considered, and with time over next 2 hours, he had progressively worsened respiratory parameters. So at the time of admission, the gas showed on oxygenation was normal, but he had high lactate requiring volume resuscitation and inotropic support. This was his first X-ray, which showed bilateral hilar shadows, streaky shadows, suggesting possibly a cardiogenic or non-cardiogenic pulmonary edema. At 3 hours, his respiratory support was escalated to nasal CPAP, and he was given dose of methylprednisolone 10 mg per kg as per prevailing MISC protocol, which included methylprednisolone and IVAG as a first-line agent in all children with suspected Misc who presented hypotensive shock. So he rightly received steroids, and we need to arrange IVAG. So it took some time. By 6-7 hours, we got IVAG, and he was started 2 gram per kg of intravenous immunoglobulin. And by the time his respiratory status further worsened and he required bag and tube ventilation, so he is intubated, and milrinone was added for hemodynamic support at 0.3 mg per kg per minute. So a PICU call was given, although we couldn't find a PICU bed at that moment. It took another 15 hours for him to get a bed in PICU. Till then, he was continued on bag and tube ventilation, adrenaline and milrinone for vasoactive inotropic support, and continued on IVAG infusion to complete 2 gram per kg. So this was his initial investigation, which showed a very high CRP and a slightly increased liver enzymes. And the hemogram showed thrombocytopenia, which has further worsened from what he had in the pre-referral investigation. And again, you can see the lymphocyte count was quite low, 5% of 6,400, which is lymphopenia. All these markers suggesting a possibility of MISC a bit more strongly now. He was shifted to PICU at the end of day 1, and he was continued on same antibiotics, and intravenous immunoglobulin was completed within next 24 hours, and he received daily 10 mg per kg of methylprednisolone for the next 3 days. His hemodynamics were stabilized with adrenaline 0.1 and milrinone at 0.5, and he was put on mechanical ventilation with a moderate settings, a PEEP of 8 and FiO2 anywhere between 40 and 60%. So we could get an echocardiography in PICU, which showed a dilated LV and LA with an ejection fraction of about 40%. So moderate to severe LV dysfunction was there on inotropy. And his left coronary artery was dilated more than 2 standard deviation. So with that, again, we have repeated his inflammatory markers and other laboratory parameters over the next 3 days, which showed lymphopenia, very high systemic inflammatory markers, CRP and procalcitonin, Also, evidence of cardiac inflammation was also present in terms of elevated BNP and LDH. He also had coagulation abnormalities with very high D dimers and increased fibrinogen. And by day 2, day 3, we could get his infection workup. His blood culture was sterile, and other tropical infection workup was not suggestive of strep typhus or enteric fever, and his antibody for anti-SARS-CoV-2 IgG was positive. Although we could do only qualitative test, we couldn't get his titers. This was his further X-ray, which continued to show bilateral changes suggesting pulmonary edema. And by day 4, day 5, he turned around with weaning of inotropic support, and he was weaned from SIMV to pressure support ventilation and further extubated by day 6. So once the platelet count improved, he was put on aspirin at 5 mg per kg. His steroid dose was reduced from 10 mg to 2 mg per kg, and then continued on oral steroids and oral aspirin. So the final diagnosis the unit has given him is multisystem inflammatory syndrome, and we could get an echo at discharge which showed good biventricular function, and ejection fraction improved from 40 to 55%. So he was discharged on oral aspirin and prednisolone with the advice to review him at 2 weeks in the follow-up clinic with a cardiology consult. So this case illustrates probably the common garden variety of MISC, which we have seen over the past 6 months or so. And yeah, so we have all learned to adjust and probably express happiness even with mask on. With that, I'll hand over to Dr. Arun Bansal for discussing about the challenges of managing MISC in India.
Thank you, Dr. Karthi, for a wonderful presentation. I think this is one of the cases which had a very classical presentation, and this has been what we routinely see. But what are the various problems or the challenges which we face? I thought I should highlight before we move to the panel discussion. I'll just take a minute. One is that it's quite a bit of overlap with the tropical infections. Because the signs and symptoms are quite similar. So especially in India or in these tropical countries, there's a lot of patients with enteric, dengue, scrub, and similar illnesses. And they can also manifest in the same way. The one thing which becomes quite a task, and you have to rule out all these diseases along with. Other is that all the places may not have access to all the investigations which are there and highlighted in the diagnosis or management or in the follow-up of COVID, especially the inflammatory markers like ProCal, BNP, and interleukins. So they are not everywhere available, or due to cost, it might be a limiting factor. Similar is the echocardiography, which is not, the expertise is not there, especially for pediatric patients, and also to look specifically for coronaries. One may be able to get an ejection fraction done, but to look for the dilated coronary arteries also requires some kind of training or expertise. The other major challenge which we faced was the overuse or underuse of steroids, mainly the overuse, because there is quite a bit of variation in the dose from 1 to 2 mg per kg of methylprednisolone to 10 to 30 mg. Various agencies, organizations, or associations have come up with their own algorithms, and they have used different kinds of doses. And so we need, the IFE and even our own institute, PGI, the government of India, have come up with their algorithms and which are more rational and evidence-based. IVIG is one of the important modality of treatment, but again, like in our case also, it took us around 6 to 8 hours to procure. Sometimes we struggle a bit more, but I know there are many institutes or hospitals or places where it is very difficult to get IVIG because of the cost mainly. And then how to follow up is another important factor, because these kids do need a proper follow-up, clinic management, and proper investigations on the follow-up. So I will leave it to that. Hopefully we can take up all these or few of these in the panel discussion. So back to you, Savik. Thank you so much.
Thank you so much, Dr. Bansal and Dr. Nalasamy, for presenting that very interesting case. And it's nice to see a nice outcome there. And it seems like this case was handled with real expertise and poise. And so I think that's nice to see, particularly with a severely ill child. I wanted to give Dr. Shulkovsky a chance to ask any questions she may have about the case, and also Dr. Hussain, if you have any specific questions about the case, and then we'll go through a couple other questions that we have. Oh, and actually, and Bijali is reminding me that we do have a poll. So maybe if we can advance to the next slide and we can get our poll done first, and then we'll turn it over to Dr. Shulkovsky and Dr. Hussain. Any questions specifically about this case? And so if you could please take a couple minutes to answer the poll question. And then we'll reinforce these concepts both in the panel discussion and then in our comprehensive resource that we'll send out after. Dr. Shulkovsky, as they're going through the poll questions, do you have any comments that you wanted to make on the case? Obviously, we're going to get our evidence-based review soon, but I wanted to give you a chance to comment on any of the challenges or things that you saw in the case.
Sure. Yeah. So I think thank you, Kartik. Thank you to the presenters, and thank you, Sovik. The one question I had was, I think this will come up in our discussion, but one of the things we've seen in our ICU is that the shock picture in MISC can be very mixed. And can sometimes be more predominantly a distributive picture versus a vasodilatory type of shock versus a cardiogenic type of shock. So just wanted to ask with the case, why milrinone was added. What was sort of the prompting clinical feature where there was a decision made to add the milrinone to the adrenaline infusion. We've sort of faced that same sort of decision-making point in our clinical care algorithm, and just wanted to ask sort of what the clinical change was that prompted that that decision.
As you have highlighted, we too have had children presenting with both types of, including vasodilatory presentation, who required noradrenaline or even vasopressin in some kids. But this particular kid, I think after adrenaline, we could get a blood pressure which is greater than 5th centile, but still the perfusion parameters were quite deranged. The perfusion was quite, he was cold and with a poor peripheral perfusion, along with persistently elevated lactate. So this prompted the team to add milrinone at that point of time.
Great, thank you.
Thanks, Dr. Karthi. And then I was going to follow that up with how critical in the management of these patients is one, the cardiac biomarkers, but also the echocardiography, as you mentioned. We obviously use that a lot in adults, particularly when we have a mixed picture to help guide our management. But if you don't have that resource available, are there other laboratories, biomarkers that you use to sort of tip you over into the, let's start treating for cardiogenic shock? And that's for Dr. Bansal and Dr. Karthi.
Yeah. In children who had presented with LV dysfunction, fortunately we have the facility of echo in our unit. So in most of them who had LV dysfunction or presented in hypotensive shock or perfusion abnormalities, we have had children having high cardiac inflammatory markers. We generally do CK-MB and pro-BNP, and found them elevated in most of the cases who had cardiac dysfunction. So it can be a surrogate for children with cardiac dysfunction. But at the same time, if you see, probably most of the centers who don't have echocardiography also have limitation of these availability of these biomarkers as well. If I see, probably in India, in peripheral centers. So most of the time we go with clinical presentation and clinical hemodynamic parameters rather than biomarkers or even echocardiography. That's probably suits more for the peripheral centers.
Thank you, Dr. Masali and Dr. Karthi, for this great presentation. Coming from a presentation point of view for somebody that works in the emergency department or that might be seeing this patient in clinic, what kind of a decision-making did you have in choosing what labs to start off with initially with having MISC on your differential? We run into this with children who come in with fever and trying to figure out which labs we want to start with and whether we do all of the labs together or ones individually.
Do you want to